introduce this morning's Gailanne Reeh lecture. Dr. Michael Hoge is a professor and director of clinical training and psychology within the Department of Psychiatry at the Yale University School of Medicine. He also serves as the director of Yale Behavioral Health, which delivers a broad array of mental health and addiction services to adolescents and adults. As a founding member of the Annapolis Coalition on the Behavioral Health Workforce, he was instrumental in launching a national interprofessional effort to improve the recruitment, retention, and training of individuals who provide prevention and treatment services for persons with mental health and substance use conditions. So with that, I'd like you to join me in welcoming Dr. Michael Hoge.
Good morning.
Good morning.
Thank you very much for that comprehensive introduction. Kelly failed to mention that I'm also a member of Costco and Sam's Club. And I got a really good deal at the Holiday Inn last night. I'm delighted to be back in Massachusetts. Those of us from Connecticut are very fond of Massachusetts. We typically view it as one of the best places for weekend escapes. But we are starting to look at Massachusetts a little differently now. We're starting to look at it as the first stop in what we call our Great Escape, or the Great Migration to Canada. That has been tentatively slated to begin on the morning of Wednesday, November 9th. I'd like the record to reflect that was a politically neutral comment. Both the Commissioner and Kelly have talked about problems in access to treatment. In great states like Massachusetts, there's a lot of fabulous treatment, and the problems are largely around access. In many parts of the nation, there simply isn't the good treatment to access. And we've talked about all the things and have worked on a lot of things that cause access problems. We started by talking with the Commissioner about stigma. We've been working nationally in the states on access to healthcare coverage, in building services, in linking services, but we always come back to the issue of workforce. Concerns that we've had for probably 4 or 5 decades or so about not having enough providers and not having providers who are adequately trained. This really sort of concern about the healthcare workforce emerged onto the sort of national stage, not in relation to behavioral health, but in relation to the public's concern about the quality of their doctors. And this is a cover from a New York Times magazine back in 2002. And you see on the back of this woman is a medicinal leech. And the quote below is from a famous medical educator. It's half of a quote. And the piece you can see here, half of what doctors know is wrong. And the other half of the quote is, the problem is we don't know which half. And back around the turn of the century, all of this concern started emerging in the public about healthcare and the push towards thinking about the competencies of the health professionals. At that same time, there was increasing concern and focus on the behavioral health workforce. And some colleagues and I founded a nonprofit called the Annapolis Coalition, and with the leadership of Catherine Power, who's your SAMHSA regional administrator now, pulled all the parts of SAMHSA together to fund a major initiative to build an action plan for the nation on this topic. And so we traveled the country and worked with groups for 2 years to build a comprehensive plan that identifies some of the paradoxes of how we are currently approaching the behavioral health workforce, a set of strategic goals and objectives, and a list of priority action items by stakeholder that we could do, that we can move on in order to address this problem. And those resources are available on the SAMHSA websites or at the Annapolis Coalition website that's listed here. But what I'd like to do is just give you a brief summary of some of the things that we found as a way to set the stage for today's discussion about how to think about the problems and the solutions to the workforce challenge. And I'm going to start by sharing with you a series of paradoxes. The first paradox is that we train students for a world that no longer exists. The evidence is very clear that it takes about 15 years for practice, once proven to be effective, to make its way into routine clinical care. And that's often due to the difficulty that our academic programs have moving fast enough to keep pace with service delivery in the field. Being in academia, I can say, and I often do quip, that strategic change in academic departments is largely based on the retirement and premature death of our faculty. And the reality is that the old guard in academic institutions hold on to the curriculum, and when they retire, the middle guard moves forward and begins teaching what they learned in school about 15 years ago. It's not always the case, but it is a pervasive problem in education to keep current with the rapidly changing field. The second paradox is that those who spend the least time with clients receive the most training. So almost the vast majority of our resources go into educating professionals. And yet when I walk onto the inpatient unit at our prestigious hospital, the psychiatrist, the nurse, the social worker, and the psychologist are usually behind the glass typing on the computers as if that's treatment. And out on the units are the psych techs, the psych aides that are spending time with clients who have had very little preparation for those roles. The third paradox is that across all of our programs, graduate programs as well as continuing education, that we persist in using ineffective approaches to teaching, largely based on one-time lectures or other didactic experiences that have been proven conclusively through controlled research to have absolutely no effect on what people do. So the image that I'm portraying here, it's as if the educator who you may see perched in the third floor window is shouting to his students as they walk by on the sidewalk, hey, hey, try this, try this. We throw out ideas, but we're not truly engaged in those educational programs to change what our providers or change what our students do. The fourth paradox is that we train behavioral health staff, though the clients usually seek help from others. Where do people go when they need help? They go to their pediatrician, they go to their internist, they go to their school counselor. These are the first points of access, and yet very little resources dedicated to educating those individuals about identification, assessment, and brief treatment of people who have mental health and substance use conditions. All of the care that is provided by professionals pales in comparison to the amount of self-care that individuals with mental health and substance use conditions engage in, and the huge role that families play in caring for their loved ones. But again, we put very little of our precious resources into building that portion of our workforce. People often say to me, we don't have much of a workforce, and I say, look around, open your eyes. There are consumers, there are clients, there are family members everywhere that are actively engaged in this process of caring for themselves and each other. We need to do more to address the opportunities. Kelly was mentioning the absence of diversity in the workforce. I hate to say this is the characteristic diversity of my field, psychology. It is 94% Caucasian. We feel these huge disconnects, experience these huge disconnects between individuals being served in terms of their background defined across many dimensions of diversity and the diversity within our formal workforce. Paradox 7 is that students are rewarded for doing time in our educational systems. What does that mean? We lay out a curricula, they march through that curricula, but there has been very little emphasis until the last decade on the notion of identifying competencies and assessing competencies for practice. I received an email yesterday from the licensing board in psychology that says they're for the first time introducing competency-based assessment for licensure, which will begin in 2019. So this is emerging, but something that we still have a long way to go to think about our focus on competencies as opposed to progressing through these curricula. Paradox 8 is that we do not systematically recruit or retain staff. We're often scrambling to find what I sometimes call any warm body to fill a position that's open. And once we find them, we have adopted the Nike approach of just do it as your basic strategy for entering and being successful in your job. And the last paradox is that career ladders to move to become supervisors and leaders are very haphazard in our field. This is image of a career ladder in behavioral health that someone has put together. This comes from a slide set called Why Women Live Longer Than Men. And I went to find it the other day on the internet, and I discovered that if you just type that phrase in, you will now find thousands of pictures. It's actually clean fun that you can have on the internet of men doing things that I'll just call unwise. So, entertainment for the weekend. So we pulled some of this together and engaged people in thinking about, so what can we do? And out of this emerged the notion of what we call the Annapolis Framework, which is a conceptual roadmap for making sense of this huge area and thinking about the activities that we need to forge ahead on. And we organize these under three broad categories. First, we have to broaden the concept of what we mean by workforce. Second is we have to strengthen what we think of as our traditional workforce. And the third area is that we have to build structures to support the workforce. And I'll walk you through the 9 goal areas that fall within these 3 categories. The first is about workforce roles for clients, consumers, patients, families, whatever language you'd like to use. We traditionally have thought about educating clients or consumers about illness, about treatment, about recovery. But moving well beyond that, we have opportunities to educate and empower them around shared decision-making about their treatment. You've seen an expansion of peer and family support roles and of employment, particularly through the certified peer specialist programs that are happening on the adult side. But we have far to go in terms of realizing the full potential of those. And one of the most exciting areas that I've experienced is engaging peers, consumers, clients, family members as educators of the professional workforce. We've been doing some of this in Connecticut, and the students absolutely love it. It's very rewarding for the consumers and family members that participate. It's often the highest rated part of the educational experience that students receive. Just one example here of another intervention. Managed care companies and states are increasingly using and employing peers to decrease hospital admissions and readmissions. Something that attends to both the cost of care, reducing the cost, while also increasing the quality and the outcomes of the experience. The second type of expansion is to expand workforce roles for community groups. This is something that has been developed in the areas of prevention with addiction, the anti-drug coalitions that have been formed, and it's a key strategy in rural areas where there hardly is any behavioral health system. And so there have been competency sets developed that can be taught to community groups to empower them to assess the nature of their behavioral health needs and to develop these community coalitions to address those needs. And we need to link those efforts then with the formal behavioral health system and its workforce. Goal 3, again about expansion, is engaging all health and social service providers in the process of caring for people who have mental health and substance use conditions. You see this happening increasingly on the primary care front, with screening and brief intervention, co-location, and consultation and referral mechanisms. We see efforts along these lines happening in emergency departments. In Connecticut, as a result of the Sandy Hook tragedy, our state legislature passed a bill that authorized a huge expansion of mental health first aid to be directed within the school systems to educate teachers and other school personnel. As part of this, my colleagues and I developed for SAMHSA the core competencies for integrated behavioral health and primary care. This blends the push towards integration as well as the push towards competencies, a sort of very practical list of competencies that you can use to guide your thinking about who you hire, how you deploy staff, how you educate them initially, and how you provide continuing education. And this is one of the resources that will be available on the center's website later today. So there's an interesting thing as we move forward with competencies and integration is we usually always think about the competency of individuals, but we have to start thinking much more about the competency of teams of individuals, or teams of people working together. This is the best image I could find of that, the notion of synchronized swimming. We're all in this together and we're all in, it's all a beautiful thing. This is what often happens in my system. I call it asynchronized drowning, as these teams clash. Developing these teams, making them functional is a daunting endeavor. So moving on to strengthening the workforce, the classic objective of recruitment and retention. We know from research that salary benefits and financial incentives have a huge impact on drawing people into a position and keeping them there. But we also know that non-financial incentives, rewards, recognitions, things that cost us a piece of paper, have a significant impact on how people feel about their jobs and about their intention to either stay or leave those jobs. We know that job characteristics matter. One of the biggest things the research shows that behavioral health workers complain about is the lack of a clear job description or clarity about their role. They're working with individuals and families who have many problems. They often have little training, and the question is, what am I supposed to do? Job clarity makes a big difference. And work environment plays a significant role. People like working in teams as long as those teams are functional and supportive. And so creating that kind of environment can also improve retention once people are hired. Developing career ladders is something that states and nationally that we can advance on. I've been working in Alaska for the last 7 years on behavioral health workforce issues, and they have systematically filled the holes in their career ladders by creating first, for example, a Ph.D. in psychology, and then recognizing that everybody was leaving the state to get their internship as the last part of their Ph.D. and never returning. And so then they built their internship program. They didn't have a master's program in social work, but they had they didn't have a bachelor's program, but they had a master's program in entry-level human service pieces. So they filled in that career ladder so that people could advance. And they've also emphasized grow your own workforce strategies. We have mechanisms through the federal government that will pay people to go to underserved areas as part of a loan repayment package. But a lot of those folks leave once they've paid off their loans or benefited from those programs. And grow your own strategies are finding people who are committed to the area, what they often call place committed, finding an entry-level position for them in the system and having that career ladder so that they can grow as they stay in the place that they would like to live. So this is a picture of our typical recruitment and retention approach. It's called catch and release. I think it's practiced a lot in Western Massachusetts. We invest all this time, as Kelly was saying, we bring people on board, and then we do very little to retain them. We let them go, and we start all over again. Building a diverse workforce, such an important objective. It's been so hard for us to make strides in this. There are a variety of strategies that the nation has been using. The National Health Service Corps that I've mentioned for enticing people into underserved areas has been booming. 1/3 of all behavioral health, or 1/3 of all National Health Corps service positions are in behavioral health. If you're in an underserved area, this may be a resource for you to recruit sorely needed professionals into your environment, and I can provide information to you about an online resource that's great that will inform you about that. Minority fellowship programs have been expanded as a result of the Sandy Hook strategy down to the master's level, not just the PhD level. In Connecticut, we developed comprehensive descriptions of career pathways and have made those available to high school counselors and others that can encourage people to consider these fields. Developmental disabilities area has perfected the notion of recruiting employees through existing employees. Those employees that you have a sense of who might do well in this work, and use your current employees to bring them in. And supervision and mentoring has a huge impact on your ability to retain people. We also know from the nation's effort to build a better workforce in the sciences that you have to start young. People make decisions fairly early about their career paths, and so we encourage you to think about reaching as far down into that pipeline as possible. These are individuals who are submitting their applications for behavioral health positions. Being a parent, but that's what they're they're adorable. Training relevance effectiveness, we need to increase the relevance, the effectiveness, and the accessibility of our training. There's a very clear logic model. We need to identify the competencies that need to be taught. We need to build those into our curriculum. We need to use evidence-based teaching strategies. We need to make sure that direct care workers are getting substantive training. We have to use technology to assist in that process. We have to make sure that every member of the workforce is educated not only in mental health, but also about addictions. It's absolutely fundamental. So I often ask, with the type of training that we typically do, is it training or really is it just exposure? And, oops, this is my answer to that question. We bring people, we take them away from their busy jobs. They have to find coverage. They'll come to a brief training. Somebody's getting unhappy in the back. I better move away from this. We give them a few ideas and then we send them back. And they don't really know anything. They don't know what to do differently. They know the message is that they should be doing things differently. And we haven't created evidence-based care. We've created what I call rhetoric-informed care. So they know how to deliver, or they think they know how to deliver person-centered, consumer-directed, family-driven, recovery, resiliency-oriented, strength-based, trauma-informed, gender-specific, time-limited, co-occurring, culturally competent, evidence-based, transformative, preventive, wraparound care. But what does that mean to them? What do we know about effective teaching? We know that there are no magic bullets. There's not a single thing that you can do to make sure that as you teach that someone will adopt that practice. But what we know is there's a whole range of things that you can do that each make a little bit of difference. So doing interactive sessions versus didactic sessions increases the effectiveness of your training. Using academic detailing or outreach visits where educators go out and briefly work with people in the field rather than bringing them to classrooms increases the effectiveness. Using reminders once people have been taught something. Remind them to do it. Audit and give them feedback about how they're doing it. Use opinion leaders, which I'll come back to in one moment. Use patient-mediated interventions. I can affect practice patterns by giving information to clients as easily as I can by giving information to providers. And social marketing is a fancy term for anticipating what the reluctance will be that people will have for engaging in a new practice and address that head on. Don't ignore it. So opinion leaders is about bringing finding people in an organization who are well regarded by others and getting them on board and having them lead. And Nightly News had an example of this phenomena last night. So you know the game Twister. It came out in the 50s or 60s and was a huge flop because people had to touch each other. And then one night, Johnny Carson and Eva Gabor, somebody like that, played Twister live on the air. These are opinion leaders in our nation, and overnight, the sales of Twister went through the roof, and it's been now in 40 countries forever. People who are highly regarded by others have an impact on what people do, and we can use that phenomena, those opinion leaders, in our own organizations. It's also been shown through controlled research that if you show people pictures of brain scans during educational sessions, that they are more likely to believe and follow what you're saying. So I would like everybody to watch this for 3 seconds. The other thing about strengthening the workforce is leadership and supervisory development. We have been moving forward as a nation slowly in building competencies around leadership and more so around supervision, and building those into processes for ongoing sort of continuous leadership development that begins with supervision, which is the first step. And all of that leads to the possibility of succession planning. The first time I heard that in behavioral health, I just laughed. Like, succession planning, come on. You know, like, I'm so busy just trying to find people, I can't even think about the future. But there are a lot of groups that take this very seriously. Here are 2. We can maybe debate the effectiveness of how they're doing it, but there are a lot of organizations that take into account the notion of thinking about who the next leaders will be and grooming them in advance. So why focus on supervisors? They are more stable as a workforce, they have less turnover, they have a large sphere of influence over what happens in organizations. There are less of them, so working with them is more cost efficient. They are the bridge from you as leaders to the people at the front lines. And if they don't like what you're doing, then you are screwed because they will undermine what you're trying to accomplish. So the rationale for working with them as your primary focus. People often ask me, there's so much to be done, what should we do? And I always say, If you can only do one thing, work with your supervisors. But my true answer is if you're going to tackle workforce, do at least two things. Work with your supervisors in the short term and bring more consumers and family members into the workforce as your long-term strategy. It is the only thing that I've seen that fundamentally over time changes the whole dynamic of how we do business. Having people in the room as part of our efforts to improve systems and improve individual care. So this is what we have run most of the nation, which is not supervision, but actually surveillance. Did you come to work? When are you going to be off next? Did you complete your records? This is what most of it is, and most of it is done on what we call a drive-by basis. There isn't a lot of scheduled supervision anymore. It's drop by the office and have these brief discussions. I had an expert in competency development from industry come into our mental health center a decade ago and help us build competencies for our team leaders. And the process involved meeting with those team leaders for 2 days to talk about what they do. And after the first half day, she pulled me aside and she said, "Oh my God, we would never ask an individual to do the breadth and depth of activities that you expect of a team leader in your organization." And here I've captured some of those roles. A team leader has to be well qualified and astute clinically. They have to be an administrator and a bean counter and an HR specialist. They have to be someone who has the interpersonal skills to be a friend, a buddy, a confidant to clients and to their fellow workers. And they have to know how to teach. And they probably have to be a lawyer too. So these are really daunting roles, and we have to step back and understand how complex they are and provide the requisite orientation, education, and support to develop the supervisors and emerging leaders within our workforce. The other paradox that we've learned is it's not just that supervisors aren't often trained, but our systems often undermine their competent performance. I see this most often in the addiction arena, where the supervisors are also assigned caseloads which are at least half caseloads, and so the notion that they will do any substantive supervision of their other workers while they're managing their own cases and the like is unrealistic. And I'll talk a little bit more about the supervision and standards issues in a moment. Financing. We all know there's not enough money. And adequate service funding is essential to have a strong and robust workforce. Connie Corrigan at Brandeis helped us when we did the National Action Plan just map out this little scenario, which is if service agencies are underfunded, we keep the workforce in an agency small, wages and benefits are suppressed, caseloads, burnout, and turnover increase. The economic burnout, or the economic benefit of becoming one of these professionals and working goes down, and recruitment becomes more challenging. We're in the area now of talking about the structures that are necessary, and we need infrastructures to make workforce development happen. We have to have functional human resource and training sections or departments. We have to have a plan. How can we make progress if we don't have a basic plan? And we need to think about data-driven quality improvement on workforce issues. A lot of times people come at workforce and they think, well, I'm going to spend some time on it and I'm going to fix it. But you can't fix it any more than you can fix quality. It's not a thing that you fix, it's something that becomes part of your lifeblood, working on in a continuous way to improve constantly sort of over time. We need information technology to support training and workforce activity and tracking, and we need good electronic medical record systems to decrease the paperwork burden, which staff always describe as variable, redundant, and purposeless. I have here a slide for you of the impact of paperwork on staff productivity. I guarantee that no animals were harmed in making this slide. And lastly, we have to evaluate what we're doing, even if we don't do research. All across the nation, agencies and states are experimenting with workforce ideas, but very few of those are written up and shared with each other. And so everybody's always starting over. And we need to assess what we're doing, even in the most basic way, and then share those innovations so that we can move forward together. A lot of people tell me that they'll say, these are nice ideas, but I I really can't achieve anything unless I get more money. I do not have more money. And my response to that is two-pronged. One is you absolutely should be a strong advocate for adequate funding of the services that are needed to meet the needs in your state. You should lean on the commissioner and the deputy commissioners and the legislators, and you should lean on your federal representatives and senators. You should be a strong voice for what needs to happen. But at the end of the day, you still have to move forward. You still have organizations to run, teams to support, and you need to act. There are so many things that you can do now that will make a difference for the people that you work with, for the nature of your own work life, and for the organizations that you're part of. Many of those ideas are suggested here. I've put together a handout which you have in your packets that lists 20 principles or strategies, and I think Kelly's going to have you do a very brief exercise with those later. But I just want to emphasize the importance of not only advocating, but also acting as we try to solve the larger issues surrounding the supports for these services and its workforce. I want to tell you about a couple initiatives in Connecticut. We got a transformation grant 8 or 9 years ago and spent half of the money on workforce. I can't tell you about all of the initiatives today, but I want to tell you about a couple. We had a higher education reform initiative. It was really based on the challenge that we had invested heavily as a state in evidence-based practices for kids, largely intensive in-home services. We had funded almost varied between 22 and 25 agencies. We had 350 to 450 positions in those agencies, and we could not find people to fill them. And we realized that graduate programs were not educating people about these services, so they weren't creating interest around them, but they also largely weren't educating people about evidence-based practices. And so we launched an initiative. Elizabeth Kanata from Wheeler Clinic in Connecticut developed with others something called Current Trends in Family Intervention, Evidence-Based and Promising Practice Models of In-Home Treatment, as a 3-credit course for graduate programs. And she built a comprehensive toolkit for faculty about how to teach this. And by comprehensive, there are 3 binders. They're about this thick all together. She developed a system for bringing in family educators, bring in families as guest educators. She built a faculty fellowship so people who were going to teach this course worked together for 24 hours of classroom-based work, and then also got mentoring as they launched their course for the first time. And we offered small amounts of stipends to the graduate programs and the teachers in order to get them on board. And Elizabeth went into faculty meetings and talked with people who thought this was all hooey, that why do we want to go down this path, and helped deal with some of the reluctance or resistance amongst some of the faculty to this initiative. And also worked to recruit students into the courses. I'd have to say that I was not very optimistic about outcomes. Living in academia, I know how hard it can be, and I was absolutely floored by what she was able to accomplish. So we now have 14 graduate programs that have participated in this initiative. 8 of them now have it as a standing elective, so it's been sustained. 4 of them made it a required course that every student has to take because it matches the accreditation requirements that the graduate programs have to demonstrate that they're teaching evidence-based services. And so the incentives were aligned. We've trained 25 faculty educators and have had 450 students go through this course with extremely positive feedback. So why did it work? We didn't just tell people that you needed to do this, like you have to be teaching about evidence-based practice. We gave them all the resources that they needed to do it. We gave them the coaching and guidance about how to do it. We aligned those incentives. We gave small monetary incentives. We gave a curriculum that was high quality and meaningful. And we anticipated that social marketing piece, so we anticipated the resistance in dealing with it head on. And we worked to connect graduating students with jobs wherever we could. The second thing that emerged from this was the Yale program on supervision. We launched a major initiative that has really 2 prongs to it. One is to change the organization by working with leadership to develop standards about the frequency, duration, and format of supervision, about how supervision would be documented, about how supervisors would be selected and trained and receive continuing education. We helped define what supervision actually is in that organization, in each organization, moving away from just administrative supervision to a supervision that's broad and encompasses education of workers and support for workers as well. And the building of supervision agreements, agreements that supervisors and workers enter into at the beginning of supervision that maps out the expectations and norms in the supervisory process. And then we provided staff development at all levels of the organization, something we call consultations and conversations that are very problem-oriented and deal with practical challenges and give practical strategies, and also deal with the very difficult experience of feeling caught in the middle if you're a middle manager, a team leader in these organizations. And lastly, focusing on self-care. I can't really do it justice in the time I have, but I'd be happy to tell each of you more about this, and provided actually a summary of it in the handouts that you have. So we talk about building a culture of supervision. People tell me we need to change the culture. I'm first very excited, and then I get really depressed because I think that's what we need to do, but how do we do it? And I actually think it's not that hard. The question is whether I can succeed in bringing up the video to show you how hard it isn't.
The gentleman in the elevator now is a candid star. These folks who are entering, the man with the white shirt, the lady with the trench coat, and subsequently one other member of our staff, will face the rear. And you'll see how this man in the trench coat tries to maintain his individuality. Little by little, he looks at his watch, but he's really making an excuse for turning just a little bit more to the wall. Now we'll try it once again. Here's the candid subject. Here comes the candid counter staff, 3 of them at least. And this man has apparently been in groups before. Now, here's a fella with his hat on in the elevator. First he makes a full turn to the rear, and Charlie closes the door. A moment later, we'll open the door, everybody's changed positions. Now we'll see if we can use group pressure for some good. Now, in a moment, on Charlie's signal, everybody turns forward. Notice they take off their hats. And now, do you think we could reverse the procedure? Watch.
So the point of that is, if you give your existing staff direction and structure and can get them lined up in one way, the new people that walk in the door will immediately fall in line. They'll immediately start doing it that way. That will become the culture. And that's what we've seen in our work around supervision, is when the standards become clear, when the people, the existing team leaders and supervisors start to practice in a certain way, the entry and the maintenance of that culture becomes so much easier. So I want to wind up here and just tell you that our nonprofit has a website, and in the bottom right corner there's this little button that says sign up. We send out 4 emails a year on the workforce updates, and so if you're interested in that, you can sign up at that link. This is kind of how I think about you and how I think about your workforce. And it really is the elephant in the room as we go about our work that we're often not sort of talking about. And the care and nurturing of that elephant is absolutely essential in order to achieve what you would like to accomplish in terms of introducing more best practices, tightening up the quality, increasing access, all the things that we depend on for the workforce. I'd like to leave you with one final thought. My colleagues and I have been at this for about a little over 15 years now, and we've adopted this quote that we live by from E.B. White, who says, "I get up every day determined to change the world and to have one hell of a good time. Sometimes this makes planning my day difficult." And to me, I think what makes it all worthwhile in any of these endeavors is having a mission and having purpose, but also having people to do it with, people who share those same ideas. And so I would encourage you in Massachusetts to sort of focus on workforce, but to find the people that you can work with to tackle many things that we have ahead of us to make the care within the state more accessible and stronger. Thank you very much.